Wow. So hi everyone, thanks for joining us in our webinar, so data challenges in a time of crisis. So we've got an excellent panel of speakers who will speak from their experience. Just a couple of things before we start and hand over to Paul. So this is the first time we're doing a webinar such as this, and we're delighted that a lot of you have accepted to come in. So there might be some technical difficulties. This might not go as smoothly as we want it to be, so do bear with us if we take a little bit more time. If you have a question when a panelist is showing their slides, if you could please use the Q&A, which is the bottom of your screen, to post your questions. And at the end of the session, around 11:15, we will take the questions and I will ask the panelist to answer your question. So we would like you to just post the question if you could, please, that would be great. And thanks to team at Metatron for sponsoring this webinar for us. And if you would like to see the agenda, which Val currently is showing on the screen now, then you can go into the AphA website and just follow the events and training from the top navigation bar, and you will be able to follow the link through to the Eventbrite website where you can download the agenda. So without further ado, can I please introduce you to Paul Stroner, who's our Chief Executive Officer for AphA. Hi, Paul.
Morning, everybody. Again, just to reiterate Ronnie's welcome to this first, hopefully in a series of webinars we'll be running on a regular basis going forward now. The idea for this one really came from some discussions we were having during our AphA coffee morning sort of drop-in sessions, which we have on a Wednesday morning. And some of our members were voicing some frustrations with what they were being asked to do, both from a national perspective and the well-rehearsed arguments around the frustrations around sit reps and definitions and all of those sorts of things, which we don't need to get into again. But also from a more local perspective about requests which were also a bit nonsensical potentially, and that sense of frustration about the gap between what was produced nationally from groups like Imperial and Oxford around sort of national high level modelling and what was required at a more local level. So we thought it'd be useful to have today's event to really capture and learn from some of the experiences from our members from across the country. And as you know, we've got people who work in all parts of the system, acute, mental health, community, trust, as well as arm's length bodies and academia. And whilst the challenge is a common one in terms of the pandemic and COVID, the response from each part of the system will be necessarily different. And I think one of the things which always strikes me is how different parts of the system don't really communicate that well with one another about what their requirements are, hence some of the frustrations you get around sit rep reporting, etc. So maybe we could unpick some of that going forward about how do we improve on that situation. So I'm looking forward to hearing not only about the challenges, but hopefully about some of the good things that have happened as well, and what has been done differently that we would like to keep once the pandemic is over and once we get back to whatever normality looks like, and what have we done differently that definitely needs to be not repeated going forward. And I'm interested in collectively people's thoughts on how do we as a community support or drive the agenda around emergency preparedness from a data perspective for the inevitable next pandemic. So really looking forward to hearing from our speakers today. I hope you'll find it interesting and stimulating as well. And as I said, for me, one of the real things about the benefits of AphA as an organisation was to have a forum to discuss exactly these sorts of things. And I've missed that over the past few months. We would have had local events or We would have been at the height of planning for our national conference, which we're still hoping to do, but in a virtual way. So hopefully this can support some of this and help to bring us together as a community as well. So thank you all for joining in, and with no further ado, I'll hand over to our President, Martin Pitt.
Thanks, Paul. Can everybody hear me okay? It's a great honour to to have the opportunity to stand on my virtual soapbox and bang the challenging, well, the campaigning tub that I've had for a long time since I started in the research world, and especially since I've moved from Manchester down to Exeter, which is primarily, it's a very simple mission, my research career. It's a mission to try and get research community more engaged and integrated with the health service community, and vice versa, get the health service community working more closely with the research community, because I think there's so much opportunity and potential that's not being realized in that relationship and could be realized in that relationship. And that explains, and one of the things that, I mean, there's lots of causes and conditions that lie behind the fact that for a long, long time, the research community and the health service community were very much two separate entities, a bit like our two hands, separate, but just touching at most and not really engaging. And in simple terms, what I've been trying to do in the last, say, 30 years, dare I say it, is to try and get the communities to integrate more closely together, to work and benefit from each other's skills and expertise. So that's one of the main reasons I'm in the research world, is to try and foster that relationship. So I'm going to share my screen now, which is just one slide, which I cannot share the slide while others, can I share it now?
I think you can share it now.
Yeah. Okay. So this is my my one slide. Can everybody see that? Okay, I'm assuming they can. So this is my attempt to characterize what the situation has been like for a long, long time, where the research community, it's got a lot of skills, advanced analytics, a lot of, and we'll hear later from Dan Cho, one of my colleagues, about how we can also offer training and capacity building for the NHS is a key element of that. How little linkage there has been in past years, and I think that's changing. I think for a number of reasons that's changing. So what I've been trying to do, if you like, is to increase the bandwidth of communication between these two communities. And the animation isn't working for some reason, but if you could see the animation in that diagram, that pipeline would get a lot wider, and then eventually the two bubbles, the two circles would come close together and work more in collaboration. So that's been my mission. And when we talk about data, I think one of the main inhibiting factors in fostering that relationship has undoubtedly been the provision of data and the information governance hurdles that are put in the way of developing that relationship. So when we talk about data, and that's behind the title of my talk, because that came from a discussion recently with a fellow researcher in Bristol University, who said that there's no point trying to do this modelling work if we haven't got any data. We can't eat if there's no food on the table. And I think that's been the frustration of a lot of researchers in healthcare modelling for a long, long time, in that, you know, we feel that we've got a lot to offer, but we can't really do much unless we've got something to work with. A bit like having a fast car but no petrol to feed it. Just sits there in the garage and doesn't get you anywhere. So we need that data, and we need to find ways in which we can share data more fully with the health services, and then feed back the useful results. And I think a lot of that, my experience dealing, if you like, with that frustration over the years, is that a lot can be overcome by developing relationships of trust between individual organisations, between individual people who work at the front line. And specifically within our group in Exeter University, the Pencord group, one of the things that's become very apparent is that as soon as the health service see that what you can offer is something that will be useful to them. And being able to show that is absolutely pivotal in allowing the data to flow more easily. If you don't do that, if you haven't got that relationship of trust between the health service and the research communities, it takes forever to get data. And many research projects have floundered because they've been unable to get the data that they've needed to drive the project. And I remember receiving an email a long time ago from a researcher in London who was complaining that she'd had to pull a £300,000 project because she could go nowhere without the data. And that she was very bitter about that because, you know, she couldn't see any reason why she wasn't able to get hold of the data. So it's been a big issue, and I think things are easing. And I think another thing that we can mention is that that relationship is strengthening all the time. And the COVID-19 crisis has presented us with an enormous opportunity because, you know, within this crisis, I think the health service organisations have begun to see the benefits that can be gained from liaising closely with the research organisations who are able to do some modelling and guide some of their activities. And some good examples of that from our patch is some work done in predicting demand levels of COVID patients for each of the trusts in the Southwest region, which was work done by the Deputy Director of the Institute of Data Science and Artificial Intelligence at Exeter, Gavin Shattuck. And that model is being used extensively now to plan ahead for the various trusts in the Southwest. Additionally, Dan Cho, who'll be talking later, has been working with colleagues in Bristol and Gloucester, looking at end-of-life care modelling and looking at some of the issues that they have to do with dealing with the COVID crisis from the point of view of end-of-life care. And another modelling work we did, and again, this was driven out of the relationships we established from some of the work we've done previously, particularly in the Health Service Modelling Associate Programme that Dan will talk about later. We did some work working with Portsmouth, looking at the dialysis service and how they could organise their dialysis service. And again, the data flowed because we had that clear relationship. We had that basis of trust between ourselves and the people who run the dialysis service, which allowed us and them to work closely together, and data wasn't such a big issue there because there was that relationship established. Mm-hmm. We didn't have to go, you know, get embroiled in the inevitable sort of cycles of information governance and ethics committees that you often have to deal with and often take months to resolve. So I don't know, I suspect things are improving. They're still not perfect, but hopefully those two circles in my slide can come together much more closely in coming time. And another thing I'd mentioned yesterday, the Health Data Research UK institution, a recently established organisation nationally, is doing a lot now to do exactly the sort of things I'm talking about, to make that data available. And then it was very exciting. They had a seminar, a whole day seminar yesterday where they were talking about some of the initiatives that are going on to make data more available for the research community. And very encouraging to see that. So I'm optimistic that things are getting better, but still a long way to go, as they say. So I hope that's enough for now. I've probably gone over my time, but I'll stop there.
I think there are a few examples starting to come out now, Martin, around the country, around a loosening of the corsets, if you like, around some of the IG rules and regulations, driven by need and necessity, really. And perhaps it's, you know, that's for me one of the things. How do we capture the energy of the crisis to make sure we retain that good stuff? I mean, there's some work going on in Kent around sharing data across the police and the health service around intimate partner abuse, which they've been trying to do for years. All of a sudden, that data can flow. So I think you're right. We've got a long way to go, but hopefully people will start to recognise the value added that non-NHS analytical functions can bring to the table, because I think it's so important. And it's been shown in sharp relief during this crisis that there has been, in some places, not all, a need for additional capacity and capability around some of the modelling work.
But I think, just to emphasise this thing about relationships, because I think a lot of this stems from establishing strong relationships between, say, research organisations like universities and with the health service organisations. It wasn't so long ago, about 5-6 years ago, that we weren't able to do a project because somebody managed to put the word research in the application. Mm-hmm. And for some reason, if you put research in a project application, it has to go through a completely different channel and gets held up in almost, all sorts of ethical approval hurdles. Whereas if you put it in as audit,
yeah,
or as process improvement, it seems to get through. So hopefully that's changing, but we have felt a bit like sort of poor relations in this world, and it's a shame because there's so much that we can do that's of value. And
absolutely.
I think the COVID crisis has presented some opportunities, because I think that people are beginning to realise that we can play a part in this now. So I think that I'm optimistic actually in terms of future developments.
Yeah, me too.
Thank you, Martin. That's great. Our next speaker is Sigal. Sigal's advanced analyst in Nottingham University Hospital NHS Trust, and also one of our champion in East Midlands branch. So Sigal, welcome.
Hi. Thank you for attending this webinar. I hope you'll find it interesting. I just wanted to preempt any misunderstanding by saying that everything I'm going to say is not the position of my trust. It's rather my view on how things have been going in terms of analytics since the start of COVID, or since the first admissions started coming into hospital. And so I'm not going to be speaking about any specific data challenge. I'm rather going to speak about the challenge of doing analytics in this at this time. And as you can see from my title, well, same old, except can you please separate it into COVID and non-COVID patients, please? Really sums it up for me. Could we go to the, thank you. So I've separated my top 5 challenges, and I've got a few subheadings. I hope I can get through all of it, but I've tried to do it more or less in order of importance for me. So if we don't get through all of it, that's fine as well. I think my top one is the missed opportunities. I know you spoke, Martin and Paul, you spoke about all the opportunities afforded. And I totally agree that there is so much potential, but I think that in so many ways, those opportunities are largely missed. For example, we've had a discharge cell put together from with all the system partners, looking at how do we discharge patients more quickly, etc., etc. But then there was a consultation period where this was supposed to be a collaboration. We were supposed to come up with ways of looking at the system and all of that. But what it turned into actually is, here is the scorecard. These are the data we want you to provide us with. Not really anything collaborative about that. Anything that we suggested was, yeah, we might do that later. Actually, all they want is the same numbers that we've always looked at, numbers of patients. Nothing about processing time, nothing more revolutionary like looking at how we're going to improve, no improvement measure, no interest whatsoever. All they want is performance measures again. A second challenge I found is that people seem to be asking the wrong questions. Instead of telling me, I want to understand why something happened, they tell me, I want to see the number of supported discharges from this ward between those dates. So basically, these display a lack of understanding of what analysts do. In fact, there is a bigger issue of what we can and cannot do that has to do with, we can't tell you about COVID because nothing in our systems has any data about it. We need to build it all from the ground up. And we did that in record time, but it's a constantly evolving thing. And we can't just tell you everything in the first day or two. And then there's also the distrusting the answers, as in there is attitude that actually we know what's already happened, we don't need you to tell us, or this is too politically volatile, we're not going to actually use your answers. The third issue I find is one of outsourcing analytics to external consultants, often paying a huge amount of money for things that actually may or may not be better than what local analysts can do. To me, this shows a lack of trust in the capabilities and skills of in-house analytics. It's maybe within acute trusts, the problem might be a bit worse than other places, but this is what I find. And what then happens is rather than doing interesting and important analysis, we end up supplying more and more data to those external consultants. And then with the results, well, it's very open to oversimplification, misinterpretation. A lot of it lacks the local knowledge. And I find that then, well, if you gave us the wrong answer, well, so what? We still got our money. There's no real accountability for whether the answers were correct or useful or helped the trust in any way. My fourth issue is the total wasting of analysts' time. One of these issues has to do with shifting priorities. So we would start work and then not finish it because now we're doing something else, and then we're doing something else, and then we're doing something else again. It's very, very difficult to do real in-depth pieces of analysis or projects. And of course, the one thing that they really must know to understand whatever is going on is always not the one thing, not on what they asked for in the dashboard or whatever piece of analysis that you've done. And then there's all the jumping on this COVID bandwagon. Can I just have that? It's really urgent. I must have it tomorrow. And of course, all of this feeds into, well, who's in charge? There's been no coordination of the work being done. Well, there was a little bit, but it was done within the analytics rather than somebody in a corporate or ops taking charge and sort of bringing together all those requests, making sure that different analysts don't get asked for the same data or the same answers. No prioritization. This is more important than that because, and one of my favorites is, can I have this without any proper data definitions? So we have received this, guidance, discharge guidance on the 19th of March. By the next week, we had to have everything set up to provide them with the data that we're compliant with all of, the whole 60-page document or whatever it was, with no real definitions on what these data items were or real understanding of how we should get them and understand them. So I'm going to close with that. I'm really sorry I went slightly over the time.
That's absolutely fine, Sigal. It was really interesting, and I'm sure looking at from the chat functions that people are commenting that you're not alone. Everybody's kind of feeling exactly the things you talked about, and I'm sure it will be quite good to discuss about that in our Q&A section. Thank you for your time. The next speaker we have is Anton Parker. Anton is the Principal Analyst for NHS England and Improvement. Anton, welcome.
Hi, good morning, everybody. I'm going to take you through a slide deck, which Val, I think, is going to very ably move through for me. So let me just get up my notes. Sorry, too many screens. So as I said, I'm Anton, and coincidentally, I started my current role as Principal Analyst for the Outpatient Transformation Programme on the first day of lockdown. So it's been an interesting and challenging time to start a new job, and that's not just because of COVID-19, but rather than tell you about the problems and frustrations that I've encountered over the last 12 weeks, I have a positive story to tell, and that's one of how, as analysts, we've been able to contribute to the delivery of a very valuable project during this time. So if we could move on to the next slide. So I'm going to tell you about how a chameleon becomes an ant. And the reason I've used this analogy is that a chameleon normally gets about a year of life from cradle to grave, whereas an ant has to pack its life into just a few weeks. So the NHS England Improvement Project to pilot video consultation platforms was always part of the outpatient transformation programme. And this element had a 12-month timescale and was to be followed by a further 2-year project to support consultation and rollout of video consultation platforms to outpatient services in England. But like so many things, COVID-19 changed these plans. And clearly there was a pressing need to enable at scale non-face-to-face consultations between service users and clinicians across all of healthcare. So very rapidly, both the scope and pace of the video consultation project changed dramatically, from procuring a platform, from its initial aims to procuring a platform, onboarding any and all secondary care providers who wanted access, and then supporting them to set up and scale use. As well as being undertaken by a newly formed project team, this project would also involve new software platforms which would be generating new data and therefore required ground up new reporting to support the project in all its stages. So how do we do it? If we move on to the next slide, I've got some points here on what I think enabled us to be successful. So the first thing is that we were part of a real team. And when I say we, I mean myself and my 2 analytical colleagues who worked as part of the video consultation rollout project team. We weren't a bolt-on service. We weren't providing that service of can we have this, can we have that, as perhaps Sigal was just describing. I was confident that this would be the case, and I hope it will continue to be throughout the whole outpatient transformation programme, because as it's probably the first time that I've seen a programme of this size where they've allocated such a large proportion of the programme staffing to analytical posts. So I think they've got a real realisation that analysis is going to be critical to the success of the programme overall. So as well as part of being a real team, it was also really important that we had stakeholder involvement, and that stakeholder involvement came in very early, that we kept in touch with them to make sure they remained engaged, and that we added more stakeholders as we needed their input. It takes quite a lot of work to do this stakeholder engagement. In my experience, it's not something that analysts necessarily seek to do as a priority, but actually I genuinely believe that it's been invaluable in this case, and is always invaluable in ensuring that you're doing the work that's needed at the time that it's needed, that it is needed, rather than doing work that you've been asked to do last week that's no longer relevant. And lastly, I must acknowledge the enabling positive elements of the COVID culture across NHS England and Improvement, and also across the whole of NHS and healthcare as a whole. I think it's been tangible that even the private companies we've been dealing with as part of this programme have shared that same mindset of that we're all working towards a common aim with a common focus. And it's obviously been a positive that there's been high engagement and high energy from people, and that people have been working extended hours. Obviously that's not sustainable, but I have to highlight the fact that it's been part of the reason that this programme or this project's aims were deliverable in such a short time. And also I think the COVID culture, has been alluded to previously, has helped with the removal of some blockers that are normally a problem for this type of work, and those are both financial, information governance, and also in this particular case around procurement processes. So as well as how we did it, I thought in the limited time I'd just give you a peek of what we produced as analysts. So if we just move on to the next slide, please, Val. So this shows our reporting evolution, and just to quickly say that over a very relatively short period of time, we moved from simple presentations of manually collated data into a more sophisticated production product. The top 2 images show evolution on tracking the progress of rollout of organisations, which had limited lifespan and therefore invested limited resources. The bottom 2 images show some of the content we've now built into a Tableau dashboard, which is in the publication environment, and should be available long into the future to provide insights into who's using the platform for video consultations. As we were tight for time, I'll leave the reporting story there, but as soon as we've cleared the last IG hurdles, then our Tableau report should be available to all via the NHS-E and I Analytics Hub. So before I finish, I'd just like to talk for a minute more on the delivery of the project overall. So if we just move on to the next slide, please, Val. So in just 7 weeks from the platform going live on the 30th of March, the program team or the project team had onboarded 181 organisations from across all of secondary care. And it was being used, and is being used, to deliver just about every type of care imaginable, even thankfully quite a lot of outpatient consultations. In the 7 weeks, at the 7 week point, we were hosting about 6,000 consultations a day, and as of today, that number is over 10,000 a day and still rising. To date, we've enabled about 110,000 hours of face-to-face care with zero risk of COVID-19 infection. Aside from the care delivered, the environmental and social economic benefits of care moving to the virtual space are also quite striking. It's fair to say that we're immensely proud to have supplied the analytical support to this project and to have been a small part in its ongoing success. And finally, I'd like to circle back to the original analogy and say that perhaps projects and project teams are quite frequently like chameleons, aloof, slow moving, with an ability to change appearance, keeping their beady eyes on everything while staying well concealed. And that perhaps sometimes we should all be more like ants, working quickly as part of a collective with appreciated clear roles for all, especially analysts. And with that, I will thank you all for listening, and I'll be happy to answer your questions in the Q&A later on or outside of this meeting if you want to drop me an email.
Thanks, Anton. That was really interesting to hear about the complex and transformation project that you've done at pace by the sounds of things. And also, it's nice to hear some good stories that's come out. And thank you for sharing your experience. I'm sure people will be asking questions. We'll pose that to you in our Q&A session.
Thanks, Rony. Next
speaker is Zoe Turner. So Zoe is Senior Information Analyst for Nottinghamshire Healthcare NHS Foundation Trust. Thanks, Zoe, over to you.
Thank you. You can see me there. If you just want to go to the next slide, there's very little on it, but there's enough, I think. I just wanted to say that when the request came for the speakers for this webinar, I initially refused because I wasn't working on anything related to the pandemic. And immediately after saying no, I thought, I can't be the only one who's not working with pandemic data, can I? Not everybody is working on models and forecasting, are they? And I'm really pleased to see Sigal's notes there, because I actually feel like I do fit in here, but I did not feel like I could actually talk at first. I'm not going to talk about the data challenges because I didn't really have any, but the challenges for data analysts. So the title for this talk refers to imposter syndrome, which is commonly felt when people feel like they will be found out that they're frauds. And we all have feelings of doubt, but persistent doubt in your abilities can plague people at any time. And I think with the coronavirus, it kind of really put it into perspective. For me, certainly, I felt like this is my time to shine. I'm an analyst with data everywhere, but I've just felt like a fraud really sometimes. It's been about 12 weeks since we've been in lockdown. I had to look that up as well, because I wasn't too sure how long it had been. And in that flurry of excitement of the momentous change, I was already working a bit from home, so that was fine. But I spent a lot of time not contributing to much, even though I was working. I'm an analyst and I have been for many years, but there's a lot I don't do. And those things were really important at that time and continue to be, like forecasting and modelling. So in those heady days of data being discussed by almost everybody, even Piers Morgan has mentioned some data, I wasn't producing anything of note related to COVID-19. Now I have a really good boss who said that repeatedly, once all this is settled, there will still be the usual work, and so to crack on. And I plugged away at my work knowing that my manager was supporting me and I was doing something to justify my salary. But then around that time, there was a redeployment of staff in my trust. And I said, well, I could take calls, or I could do some cleaning, but you know, that's really not my skill set. And it struck me at that point that what's absolutely needed then and now was analysts to work through this huge amount of data. But whilst I have colleagues who are ripping apart existing reports and creating completely new ones at a rapid rate, I was just recoding a system from R to SQL, and it didn't even have anything to do with the pandemic. And that's what's motivated me to speak at this webinar, and to openly admit that I don't feel like I've lived up to being the analyst I think I should be or I want to be. By being open, I hope to reach out to those who felt some of these feelings, even if you are forecasting modelling, and know that you aren't alone. We all have doubts, but sometimes those doubts persist, and given the situation we're in, can be really confusing whether that's us as individuals or a result of what's happening around us. And so I'd also like to say, I've never done forecasting and modelling. I'd like to say that to people when they ask me about it. The next big thing is probably going to be demand and capacity. And you shouldn't feel like you need to do those to be a good analyst. There are so many experts out there, and thankfully the presentations before me have alluded to that. So you can be an expert in your field, but maybe that field isn't what's required at the moment. We can't and we should not do everything. It's not possible with the distractions many of us face at the moment, but it also shouldn't be asked of us if it's not what we know or studied. So that's why this particular slide has a quote, because I was listening to Radio 4, the Today programme, and David Spiegelhalter, Professor David Spiegelhalter, the British statistician and Winton Professor of the Public Understanding of Risk is his full title. He refused to be drawn upon topics on that programme that were not about risk. Now, given what he does, I'm sure he could have said something on those topics, but he stood firm on national radio saying it wasn't his area to talk about. And he was really blunt. And I feel like we should too be safe in saying, no, that's not my area. And it's okay to feel bewildered at meetings, huddles, webinars, and there's been a lot of them, when people are talking about R rates or excess mortality, if that's not what you do. And it's good to go along and learn about it, but we should never equate this learning with feeling like we already know it, and consequently we're fraudulent in what we do. We all have expertise in data, which will be needed again, and might even be needed now actually, because we've got a bit of a crossover between coronavirus, pandemic, and returning to normality. And whilst there may not be huddles and webinars specific to our areas of work, as we've seen specifically for this pandemic, there will be people out there who are interested. So please, if you ever get asked to do a talk or a webinar and think, I don't have anything to say, or I really don't think I'm good at what that subject, I'm not good enough, just ignore that voice and do it. Thank you very much.
Zoe, thank you. I think you spoke very passionately, and I'm sure everything you said will resonate with a lot of people there watching this webinar. So thank you for sharing your experience. Our next speaker is Dr. Daniel Cho. Dan, thanks for joining us. Dan's a Senior Research Fellow in Applied Healthcare Modelling and Analysis in University of Exeter. Dan, thank you and welcome.
Thanks very much. So I'm going to keep this fairly brief, and it was really interesting to hear Sigal's talk a few moments ago, because actually I even screenshotted it, because I think there's a lot that Sigal brought up there that maybe some of the things I'm about to talk about could help with, and it's sort of fired off some ideas. As Martin sort of alluded to earlier, I work within the Pencore team, and been there for a number of years now. And one of the things that I'm particularly interested in is capacity building. And so for a number of years, I've led the capacity building within the team, and particularly probably our most successful capacity building initiative, which is the Health Service Modelling Associates program. And I see from our attendee list, we've got at least one HSMA alumnus in the group. So some of you may be aware of this. For those of you who are, I apologise, I'm going to spend a couple of minutes just talking about what HSMA is. But then really the purpose of me sort of talking to you today, we'd like to run HSMA again, and we'd like to run it in this new world. And we want to get your feedback about how you think this could be useful, what you think some of the challenges are, and importantly, how we can overcome them. This is really a conversation starter that hopefully we can get some feedback from you in the Q&A session. So HSMA is basically a program that allows primarily analytical staff to develop skills in operational research. And if you don't know what operational research is, it's just a very fancy way of saying using modeling, simulation, analysis techniques in order to improve the quality of decision making. So we use all sorts of things like simulation modeling, increasingly machine learning, AI, that kind of thing, in order to try and answer questions within the NHS. And really, the HSMA program is about allowing analysts who have an interest in this area to be able to do some of this stuff themselves. So primarily, the HSMA, the goal is to get OR, operational research, embedded within NHS organisations so that we can increase evidence-based decision making, enhance the analytical function of that organisation, help develop skills of NHS analysts, as Sgal mentioned that earlier, create OR ambassadors, so people that can talk within those organisations about the benefits of using these kind of methods. And crucially, and again, another point that Sgal mentioned, I promise we didn't sort of collaborate on this before, but actually fostering collaboration between NHS organisations. All the huge benefits of HSMA has been just getting people together from different organisations and talking to each other. And you would be amazed, I won't go into the stories today, but the number of problems that have just been solved just by getting people from 2 different hospitals talking to each other is astonishing. I suspect you can appreciate that. So how does it work? Basically, we have staff who are released for a day a week for a year to work on a project of importance for their organisation, and that's really crucial. We don't give them the projects come from what's needed from their organisations, their things of importance for them, and we basically train them on some of the wide range of skills that you can adopt for applying operational research, and then support them throughout the process to mentor them, provide guidance, etc. But they crucially, these remain the HSMA's projects. These are entirely project managed by the HSMAs, but we just give them, we're sort of Yoda-like in the background, giving them the nudge and the advice that they need. So each HSMA has both a Pencord mentor, so a modelling expert who can provide that ongoing advice and guidance one-to-one throughout the programme, and also a workplace supervisor, so someone usually quite senior within the HSMA's own organisation that can make sure that the work of the HSMA becomes knitted into the organisation. They don't, as we've said before, they don't become sort of the geek in the corner that's doing something weird on a Friday afternoon that nobody really understands. Actually, this becomes an integral part of the organisation going forward. So the HSMA programme is split into 2 phases. You've got a first phase which lasts 3 months, which we call Foundations of Health Service Modelling. It's basically a training programme, typically sort of 10 to 13 one-day training sessions, where we take you through all sorts of things. All of the stuff that we teach you now is in Python, predominantly Python, although we teach a bit of R as well. We teach you right from the basics of programming right up to now using those programming skills to be able to develop discrete event simulations, to model pathways, whole systems modeling. We teach you how to do AI to be able to get a machine to learn to predict things, natural language processing using techniques to try and automatically extract information from free text, forecasting, agent-based simulation to model behavior, all sorts of things. We give you a whole smorgasbord of things to look at. And not everybody will want to do everything, and not everybody will have the skills for everything, but just giving you the opportunity to dip your toe in the water and then see what might be useful for your projects going forward. All of the things we teach are free and open source, and that's really important. So there's no financial barrier for the organisation in terms of having to buy software or anything like that. And it ensures transferability moving forward as well. In phase 2, which lasts for 9 months, the HSMAs actually undertake their projects. So they get regular contact with their Pencord mentor, and then once a month they will come together as a learning set to basically share their experiences, share frustrations, challenges, successes, and crucially share ideas and talk to each other. And it's been a really successful part of the program. So previous projects have looked at all sorts of things, from modelling ED departments. We've had One who looked at using AI to improve surgical cancellation decisions, created an artificial version of their guy who made those decisions. System dynamics modelling, looking at reducing the continuing healthcare assessment backlog in Devon, modelling stroke bed requirements in Cornwall, modelling mental health crisis cafes in Devon, improving efficiency of discharge processes, using AI to improve ambulance dispatch policies. The list goes on and on and on. And it's been a huge success, and we're really proud of HSMA. We've taught over 30 HSMAs since 2016. And if you want any more information, then I can certainly provide that to you. Also, just to flag up, we've currently got on pause an evolution of the HSMA program called the PSMA program, which is the Police Service Modelling Associates program, which is a partnership that we're in with Devon and Cornwall Police to basically do the same thing with the police service. And because of the we started about 8 weeks just before the pandemic hit. That's currently on pause, but we're hoping to resume that soon. So really what I want to get a sense of from you guys today is whether you think this HSMA program, if we were to run it now in this sort of current new world, would it be useful, and what do you think some of the challenges are, and how would it best meet your needs? We're very keen to run HSMA again, and I think certainly given the points that Sagawa raised earlier, I think we can potentially help with a lot of those issues. There are challenges. Clearly, traditionally we've not run it as a virtual program, but because of PSMA, we have now started to move our content online. I don't actually think that's a big issue. In fact, I think there are opportunities from running it virtually. We've already got the infrastructure to do that. And in fact, by running it virtually, potentially you help with engagement because staff release becomes less of an issue if people don't have to travel, etc. And we can expand our reach. We can potentially go national as well with this. So I think there's opportunities. What I think some of the bigger potential problems are around getting the senior buy-in at the moment to really convince senior NHS staff that this is worth sending your analysts to, because it is a big ask. Releasing an analytical member of staff for a day a week for a year is a big thing, but actually you're getting a lot of benefit from that, and potentially if there are things that operational research modeling AI can help with right now, then maybe that's an investment that's worth making. So I guess I suppose really this is to get some ideas from you to bring up in that we can discuss in the Q&A. Primarily though, a few questions to leave you on. Do you think that HSMA is something that would be of interest to you and your organisations right now? Do you think there's an appetite, or perhaps better to say, do you think it's practical for analytical staff to be released to undertake the programme at the moment? If so, then is the traditional model of 12-month, 1 day a week release practical in the current world and within the current sort of staff constraints, and within the kind of projects that the organisations would find useful? What would you welcome most from a virtual course in terms of being able to maximise learning and ongoing support? And finally, do you think there are any other challenges, or looking at the other way, do you think there are potential opportunities that we haven't thought of here in us delivering HSMA in this new world? So I'm going to leave you with that. Have a think about that, and please sort of get back to us with your feedback, because we're really keen to see if we can apply this really successful program into this new world and help support analysts to do some really cutting edge modelling and potentially make a real difference. Thank you very much.
Thanks, Dan. That's really interesting to hear. I know of colleagues from my team and other places who took part in the HSMA program before, and they've found it really valuable. So I can see a lot of questions that came in, and I'm sure I'll be asking you about those questions in the Q&A session. So just to put a close to our panel members and their talks, I found it really, really interesting. I'm sure you will all agree that it's been really interesting. And I would like to personally thank all the panelists to make time from their busy schedule to come in and share their experiences with us. I think one thing resonating with me, and by listening to everybody that spoke, is that one overwhelming theme is that you're not alone. wherever you are and whatever analysis you're doing, these kind of experiencing, we are all feeling, and it's in the system. So we are all experiencing similar things, and kind of it's nice to hear from different people. And I'm sure whoever's there, all of you who are listening to this, you will agree. And I can see that kind of comments also coming in our chat window. It's nice to see people are engaging into a conversation and chat, and an opportunity to share and learn from each other. So one of the things I didn't mention when we started this is this, the whole of this webinar will be available afterwards on our YouTube channel. So if you have missed part of it, or if you want to take a look at it again at a later time, please do so. The link is from our website. You can find our YouTube channel. We will upload this hopefully this week, but we will send you an email with the link, and it would be on the website as a news article as well. So without further ado, from here on in, I'd like to ask Tim. So Tim and Meditrends, thank you for sponsoring this webinar event, Tim, and I will hand over to talk to us. Thank you.
Hey, if I can share my screen. Okay. Well, thanks very much, Ronnie, for giving me the opportunity to give you a quick whistle-stop tour of what Meditrends is. Just a very quick bit of background. Meditrends works with HES data. We've been working with HES data since about 2007. I think I've acquired quite a bit of experience with it, although I wouldn't make any great claims to be a statistician or any kind of wonderful analyst, but I think I know my way around the HES data. So we've been working with it since about 2007. And in recent years, as Martin was saying in his presentation, getting access to this data has become more and more difficult. We have a data sharing agreement with NHS Digital, which allows us to have the data on a number of conditions, and those conditions are that we fulfill a purpose that provides a benefit to the NHS as a whole. And the way we do that is to provide us a summary of HES data to anyone with an NHS email address or anyone working in the NHS, absolutely free. And the level of detail, I think some people find this quite surprising when they see what is available for free. So I'd like to take you on a tour through the website to show you what can be done. I'd like to talk about some of the data issues that we have, and some of the ones we might expect post-COVID or peri-COVID, and then offer some ways in which Meditrends, I think, can help you based on some of the presentations we've heard. But then a plea for how you can help us, because if we can't demonstrate that we are used and providing a benefit to the NHS, essentially the supply of the data gets switched off. Yes. So I'll try and access the site now. Okay. I'm hoping people can see this main screen now. Is that correct?
We can't see that screen, actually, Tim. I think because it's showing your PowerPoint slide. Okay, I might have to close it. Yeah.
Okay, how's that? Can we see?
Yeah, we can see that now, yeah.
Okay. Logging into the screen, once you've gone through the qualification process, and I'll explain what that is shortly, we can view HES data, assuming that everybody's familiar with HES data. It's essentially all the hospital episodes and admissions, and it's the admitted patient data set that we're looking at. We can browse this by diagnoses or procedures. So just to give you a quick skip through. Okay, so clicking on diagnoses, we get the ICD-10 classification. We can click here to drill down through, and we can click on the text of the description to go to geographical data. So let's say, for example, I'm interested in myocardial infarctions. I know they're within circulatory system. And it's under ischemic heart disease, I believe. So this goes down, in fact, to 4-digit ICD-10 code. Okay, so if we have a look at acute myocardial infarction, by clicking on the text, it takes you to a chart where you can see NHS England by region. You can see it by CCG. If you highlight a particular CCG, take Lincolnshire as an example, you can see where that sits in the scheme of things. Clicking on the title here, all of these titles will have hover over tooltips, which will get you familiar with the site. And I would encourage you to sign up and just play around and see what's there. If we look at Lincolnshire, okay, we can see these are the metrics that we have in the site at the moment. We have admissions, we have bed day cases, number of deaths, deaths per 1,000 population, and deaths per 1,000 admitted patients. These are deaths that occur in hospitals because we don't have geographic data for all deaths other than at a national level. I can show you that if we have time. We have the prevalence, which is basically the number of patients per 1,000 population. We have a couple of percentages of day cases, percentages of emergency admissions. You can see that myocardial infarctions, there are nearly all of the admissions are emergency ones, as you would expect. You can get a bigger view of any of the graphs here. So if you want to see something in more detail, if we go back here, you can see all of the data for the CCG. In terms of organizational levels, we look at, obviously you can look at NHS England as a whole, you can look at it region, or a health authority, or an STP, or a CCG, or down to an individual trust. And these are the measures that we have: admissions, number of day cases, bed days, and so on. Clicking on any of these figures will take you back to a chart showing you the geographical variation. So we're now looking at emergency admissions across the country, and North East Lincolnshire is still highlighted there. Also, for this data, you have the opportunity to go to a table. These little circles at the top here are just jump off buttons that take you to other parts of the site. So if you wanted to see this data in a table, we have it here. And of course, those of you that have worked at SQL Server reporting services will recognize the interface. So you can export this data to Excel, PowerPoint, Word, various types of document with, I have to say, a greater or lesser degree of success. We have the same kind of setup exactly for looking at procedures. So again, we can browse down through the OPCS classification. There's also a facility. If you don't know the ICD-10 or the OPCS code that you're looking for, we have a search facility here. So if I was looking for myocardial infarction, for example, I could type in myocardial infarction, you report, and that gives us all of the ICD-10, or if there are OPCS codes that relate to myocardial, they appear as well. So the site is essentially quite simple to navigate, but the idea is to give you quick and easy access to a lot of data. Okay, I'd just like to take you through what happens when you just try and access the site. If you have an NHS email address, you'll be automatically accepted as a client for the site. But before you get into the data, you need to go through a training program. This is part of our data sharing agreement. And I think it's very helpful to do this way, because you need to understand, or we need to know that people are looking at the data, understand what lies behind it and what it means and what it doesn't mean. So you'll get taken through this training program. It's very quick. Tells you where the HES data comes from, what it covers, what it doesn't cover, explains the difference between admissions and episodes. There's a lot of stuff published by NHS Digital now on national level HES data, and it's a lot of it is episode based, and as you will know, an admission can consist of several episodes. We work on admissions because we think it's more, it's a better measure. It gives you a more realistic view of what's going on in the world. So there are sensitive subjects that we don't record any data from. This is stripped out of the data before it's put onto the website. So none of these areas are covered at any level. And the small number suppression we do is above and beyond what is required, I think, by the HES guidelines. The HES guidelines say if you're talking about national data, you can show small numbers. Our view is that if you have one individual in the country who has a condition, and you can look and you can see that at a national level, and see that every CCG in the country has no admissions other than one CCG which has a suppressed number of admissions. Well, you know where that patient is. So just to be safe, because I say we're showing all CCGs, all trusts, and every single ICD-10 and OPCS code. So the granularity is immense in this. So we actually take out anything that relates to fewer than 10 patients, and everything is rounded to the nearest 5, even at a national level, because we think that people that are using this data aren't really interested in small numbers. They're not really looking at that. So this we find is a way to make sure that we can be absolutely clear about you know, the confidentiality and maintaining patient privacy. There's a bit for users about the permitted uses of Metatron's data. Again, it should be used for the purposes of benefiting healthcare. And as you're all working in the NHS, that kind of goes without saying. And a bit on copyright acknowledgement. So that's a very quick tour of the site. I would encourage you to go to the site, enroll. If you've got an NHS email address, it's absolutely free and should be straightforward. If you don't have an NHS email address, what happens is I get an email saying that you want to join, and then I can get you subscribed in the process. Again, it's just part of our data sharing agreement that we have to do that. So I hope that gives you a view of perhaps how the data here can help you. How you help us is three things really. One is do let us know by emailing me. You can get to me through Val. Do let me know how you're finding the site, and in particular if there are any measures that we have in here that you would like to see added to. There are a limited number of measures at the moment, but it's always possible to add further things. One issue is that at the moment when we're talking about admissions, we're talking about admissions where that condition is a primary diagnosis or the procedure is the primary operation. We actually, we could include admissions where it's a secondary diagnosis. And if that would be useful, do let us know that there are things we can add in. The second thing is I'd like through to contact AphA members and see if there are people who'd be particularly interested in being part of a kind of advisory group going forward to really show us how we can make this as useful as it possibly can be. Maybe deflecting some of those queries that Siegel was talking about, so distracting. If you can refer clinicians or other people to the website, maybe they can get the data that they're wanting from here. And I guess the third way you can help us is by telling all your friends. The more people we have subscribing to this site, the easier it will be when it comes to renewing our contract, which you have to do every year. So that's a quick tour of Metatrends. I'll be happy to take questions in the Q&A. I'm sure there are things that I've missed out, but I'll be happy to take questions in the Q&A afterwards. So thank you, Ronnie, and I'll stop sharing now.
Thank you very much, Tim. Thank you. We found it.
2019. The data up to March this year was due to be released on the 15th of June. It still hasn't been. I think this may be a COVID bandwagon issue, I don't know. But we're expecting the data to the end of this current financial year to be available anytime now. The issue, a data issue I should have explained, is that when we get the data, the last couple of months are often reduced because obviously there's still admissions that have happened during that month that haven't finished yet. So that's something that we need to make people aware of. But the data goes up to October 19, but it will be to March 2020 very soon, we hope.
Thank you, Tim. There is another question for you, if you don't mind. You have mentioned, lots of data, and it's useful to see those screens. Is it possible to show comparative graphs to compare maybe a couple of organizations or 3 CCGs together?
Currently not at the moment. However, I think as you saw, it's quite easy to get all the information for a single organization and download that into Excel. And you can do that several times. So yes, it is possible. It's a function that we're looking at putting in the future, certainly. But those of you that have worked with SSRS will know it's not the most friendly program to do that kind of thing in.
Mm. I think that's one of the things that I did have a concern. The ability to create comparison peer groups would be a really useful function, Tim, I think, in that would add a lot of value into your system.
I should put it at the top of my list.
Thank you. Thanks, Tim.
Thank you.
The next question is for Sigal. Sigal, it comes from David Robinson. Thanks, David, for asking the question. Do you think they were asking for the wrong data? And would anyone listen if we said so?
Yes, I think sometimes they do ask for the wrong data, or rather because rather than asking a question, they ask for data, then they may be asking the wrong question. So if they're asking me to show them all supported discharges, but they're actually really interested in medically safe bed days, then they're not going to get the right answer to what they're really interested in from what they're asking. But I think that there is quite a lot of really asking the wrong questions, or rather knowing what the answer is before before you start. And when you tell them so, sometimes, yeah, some people listen. I think that there's it depends on who it is and what group it comes from. But I think that with more experience as an analyst in the trust and more people knowing the sort of work I do, then when I say, yes, it can be done, no, it can't be done, no, it's actually not the right question, some people actually stop and think, yeah, she knows what she's talking about. But again, it depends on the chain that the requests come through to get to me in the first place. So if I get asked something directly and there's a more interaction, but that's not always the case. Sometimes it's an email that's gone through 50 people by the time it arrived, the question arrived with me. And
just to chip in there, I can't help feeling, especially Paul with you here, that's grist to the mill for your campaign to get representation as senior analysts on the boards of trusts, for example.
Absolutely, and I also think it plays into that Mind the Gap piece of work which you and Rony had done as well. That ability, I've always said for a long time that technical skills are half of the job for what makes a good analyst. You need to have that ability to distill the actual question out of the request, and that can take a long time, and it is a very skilled process to go through. And sometimes, as you said, the tendency for senior managers tends to be they want data to support a solution to a problem which supports their own pre-world view. That's not necessarily the right way to do things, as we know. So I think you've articulated beautifully a lot of the frustrations which we've all felt for a number of years, and actually some of those frustrations were the catalyst for the formation of AphA. Thanks,
Paul. So got one more question. It's from Matthew. Were there any successes you experienced? Those you highlighted, did you experience any kind of successes that you want to share through this experience? It might be hard to pull one out, but
no, not at all. We've had a lot of successes. So starting from being able to within a day send almost all analysts home to work from home. So IT being able to set all of this up with VPNs, with laptops, with picking up equipment, with whatever was needed, which I know is not exactly analysts, but still it enabled us to continue doing our work with the minimum of disruption, to being able to set up a large number of dashboards for various processes that draw on data that the week before didn't even exist on the system. So all the way from the front end of the system to the back end of the system, to through SQL, to being able to pull the data out, to being put into a dashboard used for insight and for self-service information, basically within a week. I think that's a huge success. I think it's incredible to have been able to do that, and it required coordination between huge number of different groups, ICT, data warehouse, nerve centers, the front end application, the back end application, all of those working together to do that. I think that was a huge success. Also, there is a growing appreciation that the answers that they think are right may not be right, and therefore you know, requests to write papers for a board that explains analytically with the evidence why the answer that you know, that they think is right is actually wrong, and you know, and sort of getting more buy-in for actually that no, the evidence doesn't support that, it does support something else, and being able to push this to the highest level. So I think that's a huge success as well. And maybe lastly, the one other huge success is that we're already able to look towards the future and use what we've learned to try and start planning what our services will look like in the new world, with or without COVID. But how do we pick up services? So a lot of the work we had done on why have things gone, you know, where has all the backlog of medically safe patients gone? Now we can use that understanding to plan how we're going to keep it down. So I think that that there's definitely been successes.
Thank you. That's really good to hear. Thank you. The next question I have is for Anton, actually. Anton, so there are some questions about from different people about how you are collecting data from that video platform.
So the procurement for a central national platform was done with an Australian company called Attend Anywhere, who had previously supplied or developed the system for use in Australia because of their geography, and it then being adopted by Canada because of their similar geography and obviously the need for virtual consultations. It was being rolled out in Scotland by NHS Scotland, and we were using it for the pilot. And so the decision was made to just go with them and scale that up for obvious reasons. So they actually have a very limited front-end reporting functionality for admins to pull data out of that platform. And that's currently how we're still dependent, because they've got other priorities other than setting up APIs and things which are on our wish list and will be made available not only to us, but also to providers, etc. But so the data itself only covers those providers who are doing video consultations on our Attend Anywhere based national platform. But that covers, there's about 80% of providers have been onboarded across secondary care. But I would counsel that the activity currently, the majority of it comes from only about 30% of those. So it's only a snapshot of video. And part of the problem is that some other providers are using other kind of off-the-shelf platforms like AcuRx and things. But I think there's quite a lot of video consultation activity that's going on Teams, which obviously means that it's not possible to capture it in the same way. And God forbid on Zoom. I know we're using it now, but there's a lot of highlighted security issues around the use of Zoom platform and that for healthcare consultations. So I hope that answers those questions.
Thank you, Anton. Just to add from that, were you involved in shaping or designing the data collection at all, or was it predefined by the tools that you used?
Yeah, it's very much kind of pre-canned reporting that comes out. To give you a kind of sense of the issues, the national platform's had 4 kind of major outages in the last 10 weeks, where there's been a loss of availability for part or most of the day. So Attend Anywhere's limited resources are being focused on getting the platform fully stable and scalable. So we've got a long wish list about how we'd like the reporting side of things to work and what data we'd like and to be made available, as I say, through APIs to us and others. But it's way down on their priority list, as you can imagine, when it's all about getting the platform available for providing care rather than about reporting.
Thank you. Yeah, that's very helpful. Thank you, Anton. Next question is for Dan. Dan, I know you wrote on the chat function, so hopefully your video and stuff is working okay. So thank you
here at the moment.
you too much. The question is, everyone's found it very interesting about HSMA work done in the Southwest. The main questions are coming through, will it be open nationwide?
Yeah, great, thank you. Really good question, actually. And so you're right, traditionally we have run HSMA as within the Southwest patch, and that's predominantly because it's been funded initially by by what was Penn Clark, we're now Penn Arc, which originally was set up to foster collaboration within our patch, and then latterly for the second iteration of the program funded by the Southwest AHSN Academic Health Science Network. So had a very local funding. We are particularly keen, so we're funded by the NHS-R. The NHS-R are very keen for us to be doing more national collaboration, more national work. We personally are also very keen to push out HSMA wider, and I think there's a real opportunity here actually in terms of the fact that the pandemic has forced our hand in transitioning to an online model, and actually we've already, because of PSMA, already moved a lot of content online. So we've got or very close to a working model that can work in a virtual way, so we can run a virtual program. So actually, I think there are particularly a lot of benefits from pushing this out nationally. So we would be very interested in seeing if we can run this more as a national program, because actually, once you've gone virtual, you've removed a lot of those barriers. So it's an emphatic yes. That's exactly what we want to do. I think we need to explore how we do that. But I think now's the time to be looking at that.
Just to add to that, Dan, I wonder if Paul might want to say something about the NHS-R community, because I know they've done a lot of good stuff nationally in bringing analysts together, and also whether there's a very clear role for AphA here in sort of helping in coordination of some of these capacity building initiatives.
Yeah. I think the NHS-R community, Zoe's involved in that as well. I think it's quite a good model for getting folk together around all of that, the use of technology and Slack and all of those other things, and actually encouraging people more to use things like GitHub and kind of breaking down some of those barriers and kind of removing some of the fear from it. The other thing which strikes me as an opportunity for people around the professional development element stuff is if people go through the HSMA program, we use some of that potentially as the evidence to support their professional registration, which makes it another kind of fillet for doing some of that. And we could explore within that how we might do that. So I think that's something which initially kind of springs to mind for me, but definitely I think AphA would have a role in promoting some of that in some of the work that Dan's done. Having been involved in it myself down in Southwest, a big fan of it, very supportive. I think the graduates for that are excellent, and whether or not we need to do something around using the alumni of those programs to kind of promote it on a more national footing as well, Dan, might be something we want to think about doing.
Yeah, definitely, Paul. I think that's a really, one thing that we've been doing more recently is looking at how we tap into some of the alumni. So we've got about 30 of them at least. Some have obviously moved on to other things, but we have got a good core of people. There's one guy who's down in Derriford who went through the program and is now the head of OR at Derriford Hospital, a role that didn't exist before. So there are certainly organisations and HSMAs that run with this and that are inherently interested in promoting further work in this area, and potentially even becoming mentors, which obviously the Pencore team is a small team. Unfortunately, we're not massive, so there is a capacity constraint there in terms of the amount of mentoring. But if we can tap into some of the alumni resource, potentially that frees up added mentoring capacity as well, which again helps if we want to push this out nationally.
Yeah,
I can just chip in to add to that, Dan. One of the things we've noticed with the HSMA is just the strong sense of group identity and social connection that persists beyond the program itself. We've had hackathons and things with the the alumni joining in and connecting with each other. So I think there's a real role there in bringing people together, as well as raising their levels of expertise and so on in certain areas.
Yeah, I'm a real big fan of mentoring programs, and as some of the panel will know, I've kind of done mentoring over the years and supported all that. We're currently investigating formalising that through the Fed IP infrastructure to make it more available nationally. And as you say, I think now that people are much more comfortable with this way of working, the geographical constraints around mentoring somebody have kind of gone away a little bit now. And I think so we can open some of that stuff up as well, which I think is a great opportunity. And I'm really hoping that this element of this is one of the good things that sticks post-pandemic.
Thank you. Thanks, Dan, Martin, and Paul. Dan, just another question came in. It possibly will be a yes or no answer. So would you be willing to share those open source tools, perhaps an article in one of our magazines? So the interest of people, you talked about open source tools, and people are very interested in what those tools are and if they can start testing or trying out those tools before even applying for the HSMA program.
Yeah, absolutely. So one thing I probably should have mentioned actually in my talk was that, so although we've got the HSMA program and we've got content, training content that we provide for that, we do make all of that widely available. So there is already a huge amount of resource. We can send out some links. I mean, there's a website that my colleague Mike Allen spent the best part of 3 months putting together and is fantastic, called pythonhealthcare.org, which basically takes you through learning Python for the first time right through to building an AI. So there is huge amount. We are free and open source in all senses. So yeah, we do put that content out there. The HSMA program is really more than a training program. It's a support program. So we're not precious about the training per se, because actually HSMA adds a lot of value beyond that. But yeah, very happy to share all that.
Thank you very much. That's very kind. Thank you. I have a question for Zoe now. So Zoe, lots of comments about very honest and helpful talk from you. You're absolutely right. A lot of comments around that. I just wonder what's your view around the experience of analysts in an organization. Sometimes they're largely ignored. A lot of us will probably resonate with this. So what can we do to kind of build that bridge, do you feel, with the organization, the people within the organizations?
That's a big question, and I'm not entirely sure I would know the full answer to it. I think it comes down to our relationships with people, as has kind of been said by lots of different people. I think I was in a meeting the other day when we were talking about something that was very technical, and the person who talked about it was a GP actually who's very technical, and he said that he'd spent a few hours trying to explain to the board how things were done, and then was quite disappointed that some of them just did not get it. And I felt like, well, you didn't need to spend those 3 hours, because I know that GP very well, and if he says something is difficult to build, like Google, we don't know what goes on in the background necessarily, but it's very easy to use at the front. That kind of background difficulty, if he said it's difficult, that's enough for me. And it's a bit like, that should be enough when an analyst goes, that's actually quite a lot of work, that people go, you know your stuff, you're an analyst, that's fine. But we kind of put on, there's a lot of pressure upon us, and I'm not actually a very high grade as well. So we're reliant on the hierarchy to do that for us a lot of the time. And I'm sure doctors, well, not doctors, I wouldn't say, nurses, let's say, because they're more at our level, they have a lot of power within their structure to say what they can and can't do often. Sometimes they are put under pressure, though. I do admit that it's not perfect. But sometimes when you talk to nurses, you don't necessarily realise that they're the same band as you. I think, wow, they know their stuff. They're really clinical and they've got all this responsibility. And then I find out that maybe they're a grade lower than me or the same grade. I don't know. It feels like we're on the pinnacle with AphA making a difference, but we do need to still work at it. And I do find personally, it's the hierarchical structure within the NHS. It's a lack of understanding about what analysts can do and what they can't do. Mainly it's what they can do. There's a lot of assumption that we can't do stuff. Well, who are analysts? Nobody really listens to us.
Anton.
Hi, yeah, just on that point, I think it's also about the mindset of analysts and analytical services and the people that lead analytical services in organisations, where we still kind of behave like a service provider in the same way that, you know, you ask for something and it just gets done when it can be done. There's never any case of feedback and everything else. I don't think we are viewed as somebody to consult with, generally speaking. I think I get the sense it's a case of we do what we're asked.
No, absolutely, I agree. Paul.
I'd agree with that sentiment. I would also say that that's not necessarily unique to the analytical world. In a previous existence as a statistician in the NHS, it's exactly the same. People come to you with data which if they'd have consulted you at the beginning of the process, they would have ended up with a much better outcome. So I think it's a generic, long-standing, difficult issue to address. And for me, it comes back to a lack of the right level of system leadership from an analytical perspective, and how to do that engagement, which is something Martin spoke about earlier on. So, yeah.
I'd just like to finish on saying that I feel like we should promote ourselves. You see it on Twitter a lot of social media. There are a lot of very vocal people. And so you instantly, psychologically go, they know their stuff. But really all they've been doing is being incredibly vocal. That's all it is. I mean, they probably do have the background to it, but there are lots of quiet people doing a lot of the stuff as well. So it's a lot about promotion, and that's kind of how I see AphA doing it for us and with us, and being part of it, promoting, like you would go, I can't remember, is it BMA? Is it BMA? The doctors kind of union. Everyone goes, wow, their union's big, Unison. And it's like they've just done all the promotion for us.
Yeah, thanks, Zoe. That's a very good point. I think we're nearly running out of time, so I've got one last question for Paul and Martin. It kind of follows on for all the conversation and questions that we talked about. So all of this are key role for AphA in all of this. So how can we go further and faster together? What are your thoughts?
Paul, you can go first on that.
Okay. I think with all of this, we've made significant inroads into the agenda over the last few years. I think there still remains that sort of broader engagement piece at the most senior level in terms of banging the drum, which is why I keep talking about the need for Chief Analytical Officer. I think that is missing the pinnacle of the pyramid to say, this is the person who sets the tone for the profession. So I think we do need that. I think we still need that kind of Zoe's point. We need the analysts to be a bit more demanding of this for themselves and for their community, and to say, well, it's not good enough anymore that, it's fine for finance, it's fine for nursing, it's fine for medics, medical physicists, whatever. We should have the same infrastructure to support what we do. So it comes back to that, if you want to be treated like a professional, you need to behave like a professional, and actually to have a profession. And I think it's just kind of, the noisiest wheel gets the most oil. You do need to be vocal. You're quite right, Zoe. Sometimes finding the platform to do that without seeming like a single subject fascist can be a bit difficult. But I think we just need to crack on. And in some ways, it's not an AphA leadership role, where we do have a place to play in that. I think it's an AphA membership challenge as well. Martin.
Thanks, Paul. First thing I want to say is I don't think we should underestimate just how far AphA's come in the few years it's been around. It's clearly fulfilling an important need in terms of the health service. There's never been something like AphA, as far as I'm aware, in the past that's brought together the analytical profession and the health service in the way that AphA does. And there's clearly a long way to go. And one of the things that excites me about AphA is that I've been involved in many membership organisations in the past, and often they've felt really kind of uninspired and sort of lacking dynamism and not going anywhere and just fulfilling a kind of routine need. Exactly the opposite is true with AphA. Every time I engage with AphA, I feel there's something happening. There's a dynamism there. It's moving. It's growing. It's beginning to touch important areas that it can directly address. So that's the first thing I wanted to say. I think AphA is come a long way and has got a lot to offer, and we should celebrate its successes. The second thing I want to say is that there's still so much to be done, and I think a lot of it's about recognition. And there's two sides to this. One is, we want to get the powers that be in the NHS to more clearly recognise the value of what analysts can bring. But I think there's another side to it, which is kind of what you were saying, Paul, which is we have to have the confidence to step forward too. So it's not just a question of saying, oh, they don't recognize us, you know, poor old us. It's a question of us being more proactive in pushing the agenda forward and making ourselves more prominent in the landscape of the health service. And I think in a funny sort of way, I think COVID has helped us in that respect, because I think my sense is people, you know, policymakers in the NHS and so on, have begun to realize just how important analysis, modeling, forecasting and so on has become in terms of determining what needs to happen. So I think the future looks very bright for AphA, but I think we need to embrace that potential as well. We not just wait for it to happen.
Completely agree. Completely agree.
Thank you. Thanks, Paul, and thanks, Martin, and thanks to all the panelists for giving your feedback. There are a couple more questions which we haven't got time for, but we will write to you what those questions are and the feedback from our panel members. So the next session, as you know, as I said before, once we first started, this is our first kind of webinar. We're trying this kind of platform to be able to deliver in an interactive and more in a virtual way, so more people can attend. So from that, we would really value your feedback. There are only 5 or 6 questions. So if you don't mind, we will try and make this an interactive session. So I'm going to try and do this. What can possibly go wrong? Let's try this. So on this screen, you can see Val, you had a slide up. If you could get that slide back up for me again, please. So it's the menti.com. So on your mobile phone or on the laptop you're using, if you could just open up the browser and type in menti.com, and then it will ask you for a code. So if you could please type in 381775 as it's shown on the screen. I will bring these details back up again in a second. Val, if you could close your screen, please, and I will share mine. Let me share my screen. I don't know if you can see my screen. Hopefully you'll be able to see my screen. So this is the first question, is really an icebreaker type question. So would you rather fight 1 horse-sized duck or 100 duck-sized horses? So we have, I think, about 40 people joined today. So it'd be great. So 47 participants. It would be good to see. I'm watching the right-hand side of my screen where I can see 28 people have joined in. You can see at the top of this screen, it still shows menti.com and the code if you still haven't gone in. So this is the code you need to enter, 381775, which will take you in. So I'm going to start a countdown of 30 seconds and then we will move into the real question. So lots of people wants to fight a 1 horse-sized duck. Now the numbers are going up. We have 36 people participating. Thank you everyone for trying this. We have 8 seconds and then we will move on to some of those questions. And we'll really, as I said, value your feedback. And we can also share this feedback with you afterwards, or you can see on our YouTube channel if you want to go and have a look afterwards. So if you could please just tell us about if you agree with these statements between 1 and 5. So 1 being you don't agree with those statements and the 5 being strongly agree. It's going up again, so I will set our countdown to 30 seconds. So 35 people have given your comments. Thank you. I'll just wait a couple more seconds so we move on to the next question. Thank you for your feedback. So it's looks to me the average is quite good. We still have a little bit more work to do, but we will take your feedback on board, and of course we'll improve going forward. Okay, so next question. How would you feel what do you think is a good length of time for our webinar? I think this is particularly important so we can consider that how's your experience today and what it could be going forward. So I can see people are getting used to using the Mentimeter now. The numbers are going up relatively quickly, so I will give it 2 more seconds. So thank you very much. We'll go into the next question, which is, would you attend the AphA webinar again? Don't worry, I won't see your name if you select no. we will contact you individually.
Just send the boys around later.
I was going to say,
Can I just say, as an analyst, I'm horrified by the fact that the no bar with 0 actually has a height.
That's great.
I thought we decided to make it impossible to actually select no.
There might be something like that. Okay, thank you. So the next question, and you only have 1 more to go after this one. Would you like to see more of the virtual meetings for the AphA, particularly for our regional branches where it could possibly be more accessible and more easier for you to attend if it's a virtual platform rather than face-to-face? So we will obviously from today wanted to know, and we've got a lot of our members here today. That'd be interesting for us to think about how do we operate going forward.
Just to say, Rony, those 2 options aren't really mutually exclusive, are they? Because I could prefer face-to-face, but I definitely welcome virtual meetings too.
Yes, no, that's a good point, Martin. But it seems to me that people, overwhelming majority is saying that virtual probably makes it more accessible.
Yeah, it's just that we haven't got the option to tick both, which I'd like to do.
Martin, you can log in through another device and vote the other way if you want.
Anthony, you're giving our secrets now. We'll see the number 4s going up. If it does go to 5, I will know it's Martin. So, okay. So the last question. Thank you so much for giving your feedback. Is if you could please describe in 1 word, how did you feel about the webinar today? Maybe the take-home thing that you're taking away from today, or how did you just feel as a whole? I think I could just enjoy looking through this animation. Is going. It's quite therapeutic. That's one of the words as well in the word cloud. There's a lot of interesting, lot of connected and insights and informed, which is nice to see that we're able to provide that platform for the AphA members to come together and share and connect. So that's really reassuring from our perspective to hear. And
I'm just wondering who was annoyed
for your feedback. I think annoyed, anger, possibly about the challenges people are experiencing. Maybe that's one of the feelings, and people are trying to express. So we have more people who are commenting on 1 word. I'm surprised. We now have 57 people or people probably are entering multiple entries, which is also very good. At least we'll have a good understanding. I will set this slide to end in the next 30 seconds, and then we will close our interactive session. So I think people have stopped. Thank you so much for sending us your feedback. This is really, really exciting and good feedback session for us. And we will have this, we are able to download this, and we will also show something in our magazines as well. So you will be able to see it, those feedbacks. But like you said, you can go back to our YouTube channel and have a look at slides.
I've got another one at 12.
If you like. Now, all I have left to do is I will hand over to Paul to bring us to a close. Paul, over to you. Thank you.
Thanks, Ronnie. So can I just, in time-honoured fashion, thank all of our panellists again for their input and their insights. I think the whole thing today was very insightful. I learned a lot. So I mean, some take-home messages for me. One was, I think I need to get Sigal to be more of a voice piece for AphA in terms of articulating beautifully some of the frustrations that we hear. Martin's and Tim's point about access to data, I think, is something we always need to be mindful of, and sharing across, just not across that kind of service academic barrier, but also from service to service as well, about how we do some of that. And interesting again for you, Tim, about, do you make your HES data available to the academic sector in the same way as you do to the NHS? Might be something that we want to have a think about. Zoe, the imposter syndrome and the honesty of your presentation was superb. And for me, what you did was reinforce the importance of community and how vital it is for us to stay connected, not just during times of pandemic, but throughout the year as well, be that virtually or physically. And a lot of members say what they really valued was that sense of sorority and fraternity and kind of collective, kind of we're all in this together, kind of sharing the same frustrations and successes. So that, and Daniel, the HSMA program, that run it as a virtual program and breaking down the geographical barriers and making it more widely available across the UK. I think if that's super exciting, if that does happen, I think that would be great. And once again, thank you to Tim for sponsoring the event today. Without your help, we wouldn't have been able to do it. So I think, I don't know how we do this virtually, but kind of big applause to everybody. Thank you very much, and really appreciate it. And hopefully we'll see some of you on the drop-in at 12 o'clock. And we will then look at taking on board a lot of the feedback we've had today around doing some branch meetings using this format, virtually getting together. And we will definitely use this format for running what would have been our annual conference in September as a series of 2 hour, I think 2 hours-ish, 1.5 hours, whatever the feedback was from the thing, sessions for people to dip into during the days in September that we were originally going to have it. So I think that would be great. So thank you to everybody. It's been a real pleasure today. I hope you got a lot out of it. I certainly have. And look forward to hooking up with everybody soon. Thank you.